Great. Thanks for having me. Good morning, everyone. I want to talk about prehabilitation in the radical cystectomy patient. Yes, prehabilitation is a great word. It's a new word. I want to talk about introduction to radical cystectomy, review morbidity and mortality associated with radical cystectomy and urinary diversion, talk about what is prehabilitation, talk about the program here, look at evidence for risk factors contributing to perioperative morbidity and mortality, discuss risk stratification tools for radical cystectomy, and finally, we'll look at some VGH patients and risk stratification here. So radical cystectomy is a challenging pelvic procedure involving dissection intimate to rectum, major vessels, with primary bowel anastomosis and ureteral bowel anastomosis. Requires transection of large blood vessels, venous plexuses. Our mean patient for radical cystectomy here is over 65, and most are former smokers, and almost all have comorbidities. Now, looking at the history of radical cystectomy, some of the earliest series, 60% of patients died from the surgery in the perioperative period. And then in 2003, there's a report saying there's only 4.8% serious complications and 30% major complications. So it looks like we're doing pretty well. This is an interesting quote from a paper that looked at everything retrospectively. In addition to the incidence of perioperative complications have often been utilized as surrogate measures of surgical competency, institutional quality of care, success of new surgical techniques, and have been suggested as a benchmark for financial reimbursement. So when you put it that way, we better look at everything very closely. We need a clear description of the methods of data acquisition, the indication and duration of follow-up, the indication of whether or not outpatient complications are included, definitions and inclusion criteria for at least one complication, an indication of the mortality rate and cause of death, an indication of the morbidity rate, number of patients and the total number of complications recorded, an indication of the procedure-specific complication, the utilization of a grading system to clarify severity of complications, an indication of the median or mean length of stay, and an indication of the methodology utilized to assess patient risk stratification. So after that, Memorial Sloan Kettering looked back and they found that 64% of their patients had complications within 90 days. Of those complications, 67% experienced complications in hospital. 58% of those patients experienced a different complication after being discharged. They found that 9.3% of the total cohort, or 13% of patients that had complications, had a Cleveland Deando grade 3, 4, 5 complication. They found that 0.9% of the cystectomy patient died in hospital, and there was a 2.7% 90-day mortality rate, with a readmission rate of 26%. Maybe we're not doing quite as well as we thought. So I like this quote, you gotta name it to tame it. So now that we know that we have a problem, we can try and look at it. So there's lots of moments when we can try and improve, preoperative, intraoperative, postoperative. Today I'm gonna look at preoperative. So prehabilitation is something that's kind of gaining traction. It's implementing interventions before surgery to decrease the morbidity and mortality of surgery. Focuses on physical and mental aspects related to surgical recovery. Now, what elements of prehabilitation program and how do they impact perioperative outcomes? So a lot of programs are looking at anemia. Approximately 45% of radical cystectomy patients are anemic, and early management may lead to decreased transfusions. We're looking at exercise tolerance, improved early mobility and performance of ADLs if this is optimized. Patients who are malnourished are associated with increased anastomotic leaks, surgical site infections, and respiratory complications. Frailty is something that's also gaining some focus in urology as our patients are older. And frailty is associated with increased length of stay, cardiopulmonary complications, and renal complications. There's also a focus at trying to teach patients about stoma and maintaining their stoma before surgery. And this improves their quality of life and self-efficacy of stoma care. I wonder if it also improves our length of stay, because I know that we keep patients longer sometimes because we don't know how to take care of their stoma yet. Smoking cessation. There's decreased immune response, increased wound and pulmonary complications with patients who are still smoking. And cessation before a month before surgery is protective, but if they stop immediately before surgery, it can be harmful. There's relation to ileus and other problems. And also looking at diabetes, uncontrolled diabetics are more likely to have complications, increased mortality, and increased length of stay. There's focus on obstructive sleep apnea, increasing length of stay and complications for patients who do have it, reduced fasting, no solids within 6 hours of surgery, or clear fluids within 2 hours of surgery. And we'll talk about this a little later as well, but there's some reduced insulin resistance even in non-diabetic patients with this. There are also carbohydrate loading patients before, using electrolyte carbohydrate containing fluids to help maintain lean body mass and muscle strength. And there's been shown some reduction in length of stay in the urologic literature. And unfortunately, we don't have access to elvimapan. It's peripherally acting mu receptor antagonist. There's been shown some decreased length of stay and faster return of bowel function after radical cystectomy. So if you look in the urologic literature, in the radical cystectomy cohorts, these elements have been showing questionable improvements in outcomes. And possibly the implementation of one targeted therapy will have difficulty showing benefit. But if you implement a pathway, there may be larger aggregates of smaller improvements which may be appreciated and help with patients navigating through their surgery. A prehabilitation program has been developed at our institution, and there's a multidisciplinary group that's been meeting since September of 2017. There's members from anesthesia, urology, Dr. Black, general surgery is quite heavily involved. And the intent is to best ready our patients for the upcoming surgery. So taking a look at VGH's program, they're trying to educate patients and get them mentally prepared for surgery. They're focusing on anemia, diabetes, smoking cessation, malnutrition, and frailty. There's actually a trial program right now, more in general surgery, looking at physiotherapy's impact preoperatively on patients' postoperative outcomes. So these are some slides from Dr. Kelly Mason of anesthesia. She's heavily involved in this. Now, if we look at our patients, 15% of them are still smoking. This is the NSQIP definition, so they're smoking within 1 year. 40.6% are anemic. High transfusion rate, 26%. Transfusion rate in anemic patients is higher at 38%. And many patients are low BMI or they've lost weight in and around the time of surgery. Now, looking at diabetes and hyperglycemia, approximately 15% of our patients are diabetic, and the majority of them are not well controlled. 84% of diabetic patients had glucometer readings of greater than 11.1 on post-op day 0 to 3, so we're not doing a good job in and around the time of surgery controlling them. 12.8% of non-diabetic patients had glucose readings that would make them be considered diabetic. Since starting screening all patients, 16.7% of patients were diagnosed as pre-diabetic and 11% diagnosed as diabetic that were unrecognized. And if you look at hemoglobin A1Cs of patients, 40% are between 7 and 8.5 and 13% above 8.5, so horrible control. Now looking at anemia and blood transfusion rates, there's a perioperative blood management program. The goal is to reduce perioperative anemia. Referrals to this should include all patients requiring a radical cystectomy who present with a hemoglobin of less or equal to 135, request for group and screen, and hemoglobin less than or equal to 110, and request for group and screen and hemoglobin between 110 and 130 for patients who are lower in weight, less than 65 kilograms. For optimal anemia management and hemoglobin optimization, referrals should be as early as possible. A lot of these patients are getting neoadjuvant chemo, so 3 weeks shouldn't be a problem. And include patients' weight and blood work. And really it's iron studies and CRP, which is not some other underlying reason. So if we look at transfusion rates here, between October 2014 and May 2017, there was 222 patients that went through surgery between those periods. 40.6% were anemic, and the average hematocrit was 39. There was a 26.6% transfusion rate. The mean was 2 units transfused. And if you take a look, not very many patients got 1 unit, 20%. Most got 2, 3, or 4 units. And if we look in October of 2017 to March of 2018, this is after the program's been kind of ramping up. Less patients, only 25% were anemic at the time of surgery. Hematocrit was slightly up. There still is a high transfusion rate, 29.5, but a lot more patients are getting 1 unit. Obviously, there's lots of factors that can change this. It's based on the anesthesia, the anesthetist's discretion, and how the patient's clinically doing. But there has been a trend towards more patients getting 1 and not 2 units. And so next I want to talk about risk factors contributing to perioperative morbidity and mortality of radical cystectomy patients. So we can look at it, I think, as patient, surgeon, and hospital. So if we look at the patient, there's many risk factors in radical cystectomy cohorts that are shown to have negative prognostic factors, or to be negative factors. Low serum albumin, older age, low social economic status, orthotopic neobladder, current smoker, female, dependent functional status, anemia, frailty, perioperative dyspnea, preoperative AKI, chronic alcohol consumption, elevated or reduced body mass index, reduced exercise tolerance, COPD, insulin-dependent smoking, the list goes on. This is not an exhaustive list, but just to show you there are many, many factors that can try and be impacted on. So there's actually multiple studies and show that there are obviously complications of, but that it's not actually a risk factor for a poor outcome after. I didn't include it in the slides I'll show later based on BGH's data, but there wasn't any, neoadjuvant chemo wasn't a poor prognostic factor for complications after surgery. Same with radiation, but I do have those slides. Yeah, it's true. I mean, if they're, yeah. Mhm. Yeah, good point. So now I want to focus on surgeon. So these are recent studies published. In one study, it was prospective. It was looking at a cohort and looked at surgeon volume of greater or less than 15 cases per year in 8 European hospitals that did 679 procedures, and they found no difference based on surgeon volume. In a retrospective study looking at the National Cancer Database, big study, over 900 facilities, almost 20,000 patients, and almost 2,000 surgeons, they found that 33% of radical cystectomy patients were performed by surgeons who do less than 2 a year, and 53% do less than 5 a year. They found that there was an inverse relationship between highest and lowest volume groups with 30, 60, and 90-day mortality. And they think that there was a trend that 30-day mortality may be more important for hospital volume. There are other studies that have looked at surgeon volume and outcomes. These are newer ones. Obviously, it's mostly been retrospective, and the National Cancer Database was the biggest one that I could find, so that's why I'm showing it here. This was an interesting study. It was looking at surgeon specialization and operative mortality rates in the US. It's retrospective once again. So it looked at what percentage of a surgeon's procedure is made up by radical cystectomy. And so if you look at the average specialization between everyone, it was 16%, and the average volume was 7 a year. And then they broke it down into quartiles. The lowest quartile would be 1% of their practice is cystectomy, and the highest would be 23, but a range of 5 to 72%. And they did show that there was a trend towards, as there's more cystectomies done, that it's done in an academic medical center, but they didn't look at this, so that's something that wasn't really investigated. They found that surgeon specialization divided as procedure-specific volume divided by total operative volume across all cases was associated with decreased relative 30-day mortality rates by 41% between the top and the bottom quartiles. And this appeared to be surgeon volume until the regression took into account specialization. The study didn't look at hospital volume, as from the last slide we see that's important, but it's an interesting concept. And there's a greater relative risk reduction with surgeons specializing than due to procedure-specific volume. So even if you did 30 cystectomies a year, but you did thousands of cases, that wasn't beneficial. So now if we look at hospital, Vetterlane et al. Found that there was lower 30, 60, and 90-day major Clavin-Dindo complications, 3, 4, 5, on multivariate analysis for centers performing greater than 45 radical cystectomies per year. This was at 18 centers and around 700 patients. So this is that prospective cohort that I was talking about. There was no difference in mortality in the study based on volume. And the other study looking at the National Cancer Database, also published in 2017, showed that there was an inverse volume outcome relationship between the highest and lowest volume hospitals for 30, 60, and 90-day mortality. And the SEER database, there was a study in 2012 that looked at this as well and found that there also was a strong relationship between mortality and hospital volume. Next, I'd like to talk about risk stratification tools for radical cystectomies. There's lots of different ways to look at radical cystectomies, and we have many tools to try and assess these people. Some are more complex than others. Don't know if anyone else has noticed this, but it seems like all of our patients are getting pro-BNPs drawn preoperatively and troponins after. And this actually comes from the Canadian Cardiovascular Society guidelines on perioperative cardiovascular risk. And they devised an index, and it's based on surgery, so all cystectomy patients would count their intraperitoneal, then ischemic heart disease, CHF, CVA, pre-op insulin treatment, and CKD, and each item would be 1 point. So then most cystectomies are elective. Most of our patients are over 65, so basically every single patient is going to be getting this, most likely. And what it's been good for is it's thought to be better at predicting myocardial infarction post-operatively compared to another good risk stratification tool, which we'll talk about later, and that's the NSQIP risk calculator. And they say that's better because NSQIP didn't look at drawing troponins post-operatively, and 50% of patients have silent MIs in the post-operative period, or 50% of patients who have an MI have a silent MI. So we're going to look at some of these risk stratification tools. There's the Adult Comorbidity Evaluation Index 27, ASA score, everyone's familiar with that, ECOG, Charlson Comorbidity Index, preoperative score to predict postoperative mortality, frailty, and then we'll finish off with the ECS and NSQIP risk calculator. So this is a retrospective study that looked at 550 patients undergoing radical cystectomy. It looked at ASA, ECOG, ACE27, and Charlson Comorbidity Index. It developed chi-squared indexes and area under curve for receiver-operator curves to determine the significance of the models. So it created a base model and then looked to see how these risk classification tools improve the model. So if you look at the ASA and ACE27, they were considered equivalent. The ACE27 improved the base model by 29.8%, it was better predictive, and ASA 28.3%. So they're pretty equivalent. ECOG and Charlson Comorbidity Index are actually pretty poor at predicting, and we'll look at the Charlson Comorbidity Index later. It's been compared to other studies, but there's a lot of variables in it. I'm not sure if everyone's familiar with ACE27. I wasn't, so I thought I'd show you guys. Patients are classified into having none, mild, moderate, or severe disease based on number of organ systems involved. Essentially, it's all the major organ systems. You get a point for each, and then that classifies you. ASA, I think everyone here should be familiar with this. Developed in 1941, stratifies patients in 5 categories. Now, it can be predictive of both 30 and 90-day mortality in cystectomies, but there's significant limitations. It's subjective. In the literature, there's between 40 and 60% agreement between anesthetists. It's simple, which is also a strength and a weakness. Everyone understands it. It's easy to calculate, but it has poor reliability. So this is POSPOM. It's the perioperative score to predict postoperative mortality. It was developed in a French population using more than French hospitals having more than 500 procedures per year. 7 million patients were involved in over 1,000 centers. What it wanted to do is predict in-hospital mortality. So it's looking at all the usual kind of stuff. It looks at age, ischemic heart disease, cerebrovascular disease, cancer, diabetes. And they looked at the surgery you're undergoing as well and assigned it points. So major urologic surgery, which obviously radical cystectomy would fit within, gets 12 points. So this was a study that looked at POSPOM in radical cystectomy patients. And so if you think of our average patient, they're over 65, so they're going to get 10 points for their age, and they'll get 4 points for having cancer, and they get 12 points for major urologic surgery. So you're at 26 points right off the bat, which predicted from this would give you a 2% in-hospital mortality rate. Now, for this study, they found that there was an over-prediction in their study of the in-hospital mortality rate, and they thought if you take off 5 points that you're more around the mortality rate seen in hospital. So if we take off 5, we're at 21, so there's about 0.5% risk for our patient who has no comorbidities, which I'm sure you guys haven't seen very often. Next, looking at frailty. Age is not always thought to be the best marker of poor outcomes after surgery. There's increasing interest in understanding frailty's role in development of complications postoperatively. And there's been a discordance with ASA or age-based assessments. Frailty can be defined as a biologic syndrome of decreasing reserve and resistance to stressors, resulting in cumulative decline across multiple physiologic systems and causing vulnerability to adverse outcomes. There's lots of different ways to look at frailty. One of the best ones that was actually developed in Canada is the Canadian study of Health and Aging Frailty Index. 70 items we'll look at it. It's kind of complex. You're probably not going to use it in your clinic. There's a modified frailty index, extended frailty index, simplified frailty index. Studies have looked at these and found that they're actually pretty similar. A 5-item frailty index almost predicts as well as the 70-item one. What's interesting about this is if you look at some of these, poor muscle tone in neck, sucking problems, poor muscle tone in limbs, memory loss, paranoid features. These aren't things that we would normally maybe notice in clinic, but they can have an impact on our patients. A study that looked at the frailty index versus ASA found that it was actually inferior to ASA. We have a 70-point checklist that's worse than ASA, and it was superior to Charleston Comorbidity Index, so for predicting 30 mortality. But it just shows that sometimes these big lists don't actually really help us very much. It showed also that some of the smaller lists, the 5 and 11 item lists, are actually as good as the 70-point list. So there's still a lot of room to improve. And I think the real question is which patients can be identified with a frailty index that would be missed by other evaluations like ASA, trying to find patients that are at higher risk and help them before they go into surgery. So this is a retrospective study looking at the NSQIP risk factors, which we'll talk about a little bit later, and comparing it to ASA score. And it found that the NSQIP risk factors are actually superior to ASA score, and combined it's even better. You're having C indexes of greater than 0.8 or 0.9, which would be good to excellent. And that leads us to talking about the universal risk surgical calculator. I don't know if anyone's ever used this before or is familiar with it, but essentially you kind of plug in your patient's variables, and then it gives you a score. What's your patient's risk of having death? These are all 30-day and specific definitions, but it can maybe give you a better idea of what problems they may encounter, help you educate your patient about the risks of surgery. It was developed in 393 hospitals. 21 preoperative factors determine 8 outcomes, and there was over 1.4 million patient outcomes. Every procedure is stratified based on code. So cystectomy out of conduit would be one, cystectomy urinary diversion is one, cystectomy without lymph nodes is one. So they do really try and break it down. Only one study attempted to validate the universal surgical risk calculator in the urologic surgery, and this was looking at 300 partial nephrectomies done robotically. The data was incomplete. They thought that they didn't have information for diabetes, so they assumed all were oral, which we'll see later is very important if it's oral or insulin. They didn't have smoking status, functional status, disseminated cancer, dialysis, acute renal failure, systemic sepsis. Ascites and ventilator dependent was missing. I think that patients weren't ventilator dependent for getting a partial nephrectomy. They did include that. And they used Clavin-Dingell complication classification, which we'll see is actually quite different than looking at the NSQIP risk calculator definition. Their definitions are quite rigid. They found that the surgical risk calculator was poorly predictive and maybe not useful. So next I want to take a look at the VGH patients and risk stratification in VGH patients. So we looked at a study here, 250 patients, cystectomies between 2013 and 2017. And this was just patients who were within the ERAS program and excluded benign disease, including follow-up, undergoing additional surgery. So if they had a hemicolectomy, cholecystectomy, anything that was thought to be a major deviation, or if surgery was aborted. There was 18 robotic cases, all were extracorporeal urinary diversion. There was a NSQIP review, chart review, and a separate EMR review. Patients were entered into the NSQIP risk calculator. There was a comparison between predicted and observed complications, and analysis to determine risk factors significant for complications. So looking at our patients, these are all variables that would be plugged into the NSQIP risk calculator, but 30% of our patients were less than 65, 42 were between 65 and 74, and some of our patients were older as well. 50% of our patients were ASA2, 40.4 were ASA3, and a couple ASA4 slipped in there. Less than 10% of patients had disseminated cancer, severe COPD, chronic steroid use, or were functionally dependent. Now, in terms of diabetes, 11% had diabetes but required only oral treatment, whereas 7% required insulin treatment. And 16% had dyspnea, and no patients had dyspnea at rest, it was only with exertion. And 19.7% were current smokers. BMI over 25, 70%, so 70% of our patients are classified as obese. 52% had hypertension requiring treatment, and 83% were male. No patients had ascites, CHF within 30 days, sepsis within 48 hours, or acute renal failure requiring dialysis or were ventilator dependent. That's just for other things that would be included in the calculator. 12% of our patients had previous radiation therapy. We do 25% patients continent diversion, very few are done as Indiana pouch. 31% got neoadjuvant chemo, and in terms of pathologic stage, I didn't include which patients had neoadjuvant chemo, but 47.5% were pathologic TA, T0, T1, or CIS, 17.9 T2, and 31.8 T3 to T4A, and there's only a couple of T4Bs. And there was a couple non-bladder primaries. As you'd expect, most of our patients had urothelial carcinoma. We had a couple micropapillaries, sarcomatoid neuroendocrine or other variants, and 12 patients who were non-bladder primary. So this is what you get when you plug in the patients into the risk calculator. It gives you risk of renal failure, cardiac complications, pneumonia. And if you look at renal failure, pneumonia, discharge in nursing or rehab facility, DVT or PE, and like to stay longer than 7 days, those were significantly over-predicted by the NSQIP risk calculator. And in our cohort, UTI was under-predicted by the risk calculator. Now, we did receiver operator curve, area under curve, C statistics to try and find out which of these was significant. And we also looked at Breyer score as well, which is just a way to see, is this random or did it actually predict outcome? And so when you're trying to look at this in terms of, is this actually predicting, there was good predictability for cardiac complications, fair for pneumonia, and poor for mortality, UTI, serious complications, and any complications. So it's showing to be more predictive than has previously been seen. Now, we did a multivariate analysis looking at risk factors determined significant by univariate. We did as threshold of 0.2, but also did as 0.1. Kind of looked at it multiple ways. And in our cohort, diabetes, insulin dependent, was a significant negative risk factor for postoperative complication, both for any complication and serious complication. Length of stay was significant on univariate, but not multivariate, same with mortality. So this is just to give you a sense of the differences between maybe something you're more used to using, like the Clavien-Dindo classification and NSQIP. Looking at serious complication definitions, a return to OR, UTI, so they do consider UTI a serious complication, sepsis, deep incision or organ space, surgical site infection, unplanned intubation, wound disruption, cardiac arrest, MI, pneumonia, renal failure, or DVT-PE. Some of these, I don't know that people here would consider serious complications. So it's good to highlight that difference so you understand when you see the numbers come out. We also looked at, this risk calculator gives you a definition, but can it predict for something that we might find more clinically significant, like Clavien-Dindo complications? And if you look at the C statistic, it was 0.62 for mortality, which we saw previously it did have poor predictive value. And for serious complication, it was 0.56, which would say failure to predict. And any complication was 0.61, which would say that we have to do prior testing. But if you actually look at the numbers, so of the predicted serious complications, the NSQIP risk calculator only predicts 25% serious complication, but we observed 11%. And that's the difference between Clavien-Dindo and the NSQIP risk calculator. And if you look at any complication, it's only going to predict 28.8%. In our population, it was 67.3% for any complication, including increased length of stay. Looking at multivariate univariate analysis, none of the patient risk factors were significant for Clavien-Dindo complications, both any and serious complications in our study. So the radical cystectomy has significant complications. Prehabilitation is an under-researched area which has significant opportunity to improve patient outcomes after radical cystectomy. And ACS, Universal Surgical Risk Calculator, likely represents the best stratification tool. So it is something that we should look at using if possible to help educate patients and select patients who might need more attention. And I'd like to thank Dr. Black and Dr. Kelly Mason for helping with this talk.